Okay, hi everyone. So today we will discuss about the pacemaker modes and their uses. Okay, because I have not uploaded anything about pacemakers. So let's start with the basics of pacemakers. So what are pacemakers? Pacemakers are those which will trigger either ventricular activity or atrial activity from a generator through a pacing lead. This is what is a pacemaker. Usually the generator may be subcutaneous or it may be in the abdomen, or sometimes the generator may be from the temporary pacemaker insertion outside the body also. So where does this generator will generate the electricity required for the contraction of the ventricle? How does the contraction of the ventricle will happen? From the leads. The leads will be connected either by tinted or by screwed to the either ventricles or the atria. So this is the basic phenomenon how a pacemaker works. Okay, so usually generator battery is around 5 to 10 years, and you can use it. The end of the life events will occur or it will be shown in the generator, and every yearly you would have to have a checkup. So coming to the basic model, how will you identify and how will you name nomenclature of the pacemakers is the four. Actually there are five nomenclatures. That is, one is first is chamber paced, second is chamber sensed, third is response to sensing, fourth is rate adaptive, and fifth is there that is called multi-site pacing, but that we don't use a lot. And these four are important, and in that also the fourth one is rate adaptive. In the sense, the patient, if he is a young person, then you need to have a pacemaker rate which is, well, when he is exerting, the pacemaker rate should go from 60 to 80, because he is exerting and the physiological response will be 60 to 80. So in those patients there will be a sensor in the respiratory system which will be incorporated with the mechanical ventilation and all. So that ventilatory response will be triggering the rate response. So that's what is called as the fourth one, that is rate adaptive. If you are not using that, then you don't need to mark it. So what are very important is 1 2 3. As you know, we usually use VVI, DDD, AAI nomenclature in the pacemaker. So this one I will go through fast. Whatever the chamber paced, chamber sensed on response to sensing, these are all with response to the pacemaker generator, not with response to the heart. That is very important. That means what I am trying to tell, that is OAVD, is that if there is a chamber is paced or the sensing, what it is going to sense is the chamber which is getting a generator. Like if the atria is having a stimuli, the left atria, right atrium has having a sinus rhythm or sinus atrial depolarization, then this S is of the generator. Generator is sensing the atrial depolarization. So this generator is sensing the atrial depolarization. That is, it will be coming as sensing of the atrium. So what will happen to the sensing of the atrium? If there is a sensing of the atrial depolarization, the pacing of the that atrium will be inhibited. That is what is given here. So if you have a chamber, that is the pacemaker lead is in the atrium, then you have a sensed pacemaker lead in the atrium. The atrium is having depolarization, then that chamber is being sensed by the generator, and that chamber will be, if you have taken the I, usually I, the response to sensing, that is sensing of the atrium, the inhibition of the atrium of pacing will happen. That is called AAI. In the similar manner, if you have a VVI, that is the ventricle is sensed of the normal ventricular depolarization. You are sensing a normal ventricular depolarization. What will happen? It will inhibit the pacing of the ventricle. The generator is getting inhibited, not the ventricle. So whatever the I is for the generator. What is T? T is triggering. That will come in a DDD kind of configuration. So what we have, there is a chamber pace, that is first one, that is either O, that is none, no chamber is paced, either A, that is atria is getting paced, or V, that is ventricle is getting paced. When it is getting paced, when a sensed atrial activity or a sensed ventricle activity is not coming, then the ventricle will get paced. Otherwise, the atria or ventricle activity sensing is then there, the response to sensing is the inhibition. So what we will do is we will go with a normal usual nomenclature and the modes we use. The most common mode we use is the VI. It is a most simplest, other than the magnet we have put, that is Vivo or AOO is the most simplest, but other than that what is we usually use is the VVI mode. So what is VVI mode? First letter is pace, second letter is I, sense, third letter is I is inhibition. Most of the time we use I, inhibition, because inhibition doesn't reach electricity, so the battery will not die, the generator will not die early. If you use everywhere triggered activity, then trigger will need a generator activity, generator electricity, that then usually the pacemaker will die early. So usually I is the one which we use usually. So VVI, so what it means? That means the ventricle is getting paced. When is the ventricle getting paced? That is, generator will have a electricity to the ventricle of about 0.5 or 2 to 5 millivolts. When it will happen? When will the ventricle pace? When the ventricle doesn't sense any ventricular activity from the atria. That is usually in the atrial fibrillation with controlled ventricular rate and decreased ventricular rate, when there is AV node is absolutely ablated, we have ablated, or physiologically it got ablated. So in those situations what happens? The ventricle is not getting sensed, then the ventricle is getting paced. If ventricle is getting sensed, then what will happen? Ventricle will get inhibited. So I will just give an example here. There is a P activity, that is atrial activity is coming. Usually after some conduction time, that is the AV nodal delay, that's what is the pacemaker will be fixed like 80 milliseconds or 120 milliseconds, whatever the milliseconds you want, that will be having a AV delay. So after that AV delay, if there is a ventricular rhythm is coming, ventricular depolarization is coming, then it will be sensed by the generator, and it will inhibit the pacing of the ventricle. So what is happening? The first one is there is a ventricular activity, so the ventricle is not being paced. It's a normal sinus ventricular activity. Then after some time there is a SA nodal delay, it has been generated by the generator. So there is a AV nodal re-entry or recovery delay, and then is a AV nodal delay. After that also, if there is nothing coming, no ventricular depolarization is coming, so what is happening? The generator is not able to sense any ventricular activity. What it will do? This generator in itself will generate a ventricular pacing. So what will the ventricular pacing? It will be in the RV. So RV pacing will be like the LBBB. So we will get a LBBB morphology in the ventricular paced, that is generator paced rhythm. So still when it will wait, wait till the recovery time and then the AV nodal delay time. The both combined is about most probably 120 milliseconds or 200 milliseconds, and it will wait for that time till if there is any depolarization in the ventricle. If the depolarization in the ventricle is not sensed, then it will trigger a ventricular pacing. So ventricular depolarization is triggered by a what is that? Generator. So you are getting the point. So ventricular is sensed. If the sensing is there, it will not pace. If the ventricular sensing is not there, it will pace. The sensing is there, it will inhibit the ventricular pacing. That is VVI. Most commonly used in atrial fibrillation with low ventricular rate, because you don't want to actually atrial rate should not be tracked. If you track the atrial rate, because if you put the AAI or even DDD in these modes, the atrial rate will be tracked. The atrial rate will be in 150, 300, 400. So this tracking will happen and the ventricle rate will go like that. The atrial activation and the ventricular activation will be going to 200, 300. So we don't want, that's why it is a VVI. And then is the AAI mode. What is AAI mode? The atria is sensed, atria is paced if the atria is not sensing, if atria is not paced if the inhibited, if the atria is sensed. So where we are using it the most commonly, where the AV nodal conduction is normal. AV nodal conduction is normal. Very important, because if you pace an atrial rhythm, suppose it doesn't conduct to ventricle because of the AV nodal blockage, then what happens? The ventricle will not be paced or ventricle will not be sensed in any way, because we are only sensing and pacing the atria. That means if there is no atrial sensing, that is SA nodal dysfunction with AV nodal, SA nodal dysfunction with AV nodal normalcy, AV node is intact, then only what happens? The SA node is not being sensed, then the the atrial lead will be pacing. So atrial lead will be having a atrial pace that will be conducted to the anteventricular node, and then a normal sinus rhythm will come. So AI is very important because it will maintain the synchrony, that is atria will be contracting with the ventricle and then the synchrony will be intact. But in VVI there is no synchrony, that is the ventricle, the atrial activity has nothing to do with the ventricular activity. Atria will be contracting at a fixed rate about maybe 80 or 90 or 30 or 40, but we have fixed a ventricular rate of about 60. So when it is in the 80, at some part of the time at the 40 between, the atria will contract and ventricle will also contract, because ventricle will be sensed by the pacemaker and it will be pacing because of the at a fixed rate of 60, but atria rate will be varying from 40 to 80 and all. So atria may contract against the ventricle, causing the pacemaker syndrome, because it will be like a CHB, complete heart block, AV nodal delay will, or AV dissociation will be there. So AI is synchronous mode. The issue is that the AV nodal dysfunction we can't use it. AV nodal dysfunction we can't use it. So what we have to do if there is an AV nodal dysfunction and we want to maintain the synchrony, that is atria should contract with the ventricle. Atria will activate and then the ventricle should contract. That is what is the synchrony. So how can we do? We can do it by D mode. That is, it will be dual, either sense or in sense or pace atria. Atria will be sensing will be both atria and ventricle, and pacing will be both atria and ventricle, and response to the sensing or pacing will be either triggered or inhibited. In a way, what I am telling is, you see that there is a impulse. What the pacemaker generator will do is that it will try to look for a atrial sensing or pacing. So what I am waiting is that there is an atrial lead and it is looking for a atrial pacing or sensing. So what will happen for the first scenario is that the atria is having its own rhythm depolarization, so it is sensing. So what will happen? It will inhibit the triggering of the atrial pacing. So first one is inhibition of the pacing of the atria. So sensing and sensing happened, so pacing was inhibited on the atria. So normal P came, and then the AV node is intact, then came the ventricle. So when it came to the ventricle, it will fixed AV nodal delay. It will try it if the AV nodal, during this AV nodal delay, if there is a depolarization in the ventricle, that is normal depolarization in the ventricle, that is after the PR interval a normal QRS is coming. So this ventricular lead is sensing that there is a ventricular sensing, so it will inhibit the pacing. So what happened? The normal scenario is that P came and QRS came and T came. This is a very normal scenario. Here the pacemaker is not at all doing anything, it is only sensing it and inhibiting the pacing of the heart. So it's a normal synchrony maintained. The second scenario, what may happen is that the atrial activity is not there. Atrial activity is not there. So there is no sensing. It will wait for a limited time like 20 millisecond or 40 millisecond, and then what will happen? The atria will be paced. Atria will be paced. So there is a pacing of the atria. So now the AV nodal conduction will happen. It will wait for 120 milliseconds or 80 milliseconds, whatever the AV nodal delay you have timed. And then what happens? The ventricular it will wait for the ventricular depolarization. So now is happening, the atria is being paced, but when it came to the ventricular depolarization came. So what will happen? The ventricle will be inhibited. So atria will be paced, ventricle will be sensed. So A is the pacing and V is the sensing and I is the inhibition, is the triggered activity. It is a DDD mode, so it can do anything. So first one was both sensing only. So atria was sensing, ventricle was sensed. So there was sensing of the atria and ventricle, so there was a normal sinus rhythm. And second one was atria was paced, ventricle was sensing, and it was also inhibitor, in the sense there was a triggered atrial activity, that is paced atrial activity, and then a normal ventricular stimuli. In both these scenarios you can't make out whether it's a normal sinus rhythm or a pacemaker rhythm. Only the pacemaker spike can be seen in some of the defibrillator ECGs. Otherwise, you can't make out whether it is a sinus rhythm or paced rhythm. What is the third scenario is that a normal sense, the atrial activity may be coming, that is P will be there, a sensing of the atria will be there, so pacing will be inhibited from the atria. And when you come down, what will happen? There is no conduction of the depolarization. So after the 120 milliseconds of ventricular delay, it will sense that the ventricle is not being sensed, so it will pace. So what happens in this scenario where there is a sensing and pacing and inhibition, that is atria being sensed, that is normal P wave, followed by 120 millisecond of the AV delay, but there is no pacing from there is no sensing from the ventricular depolarization. So this will be a ventricular pacemaker rhythm. In this one, you can easily see that this ventricle is being paced. Here it will be acting more like a VVI or AVI, but in that scenario you have a synchrony. Synchrony is maintained, that is atrial activity is in situ, but the ventricular activity will be following after some time of the depolarization of the atrial depolarization. So synchrony is maintained. This is not AV dissociation. So but the rhythm will be looking like a LBBB morphology, that is it may be looking like a VVI pacemaker, but the synchrony is usually maintained. But if that is the physiological response will be there, 60 rate, if the atrial rate is 60, the ventricular rate will be 60. If the atrial rate is 80, the ventricular rate will be 80. So 1, 2, 3 scenarios happened. In 1, 2 we can't make out whether it is a sinus rhythm or the pacing rhythm. In 3 we can easily make out that it's a pacing rhythm. Fourth is both paced, like the atria is also not having any activity, so you have a paced atrial activity, and then is after 120 milliseconds delay you don't have any ventricular depolarizations also, so the ventricle will be also be paced. This is a last one, that is A paced and V paced, and whatever happens is the inhibition. If the sensing happens, then is inhibition. So what is happening? First is all sinus rhythm, everything will be sinus rhythm. Second is only atria will be paced, but ventricle will be sinus rhythm. It will also appear like sinus rhythm. Third is atria will be sensed, but ventricle will be paced, so it will look like a VVI pacemaker, but the synchrony is maintained. And third is both are paced, like P is also like paced rhythm, and ventricle is also paced rhythm. It will also look like VVI, but the synchrony is maintained, that is 60, 80 all. And last one is the AOO or VOO mode. What is very important? Well, when we put the magnet on the pacemaker, it will go into the VOO or VAO mode. It is only done in during surgeries where electrocautery is used, because if you activate the cautery current, then it may trigger as a pacemaker may sense that the ventricular activity is coming, because there is an electrocautery. Cautery can generate some current, so the generator will feel that there is a electrical activity depolarization in the ventricle, and it will not at all pace. So the patient may go for a continuous systole during the operation. That's why you need a VOO mode. VOO, that is always pacing, no sensing and nothing doing. Whatever the ventricle will come, it will just whatever the ventricle will come. So VOO mode, the ventricle will be paced, whatever the sinus rhythm ventricular activity is there. So it is different from VVI in that there is a P wave, and then there is a ventricular pacing at a fixed rate is coming. This is a ventricular fixed rate is coming. Even if in between a ventricular depolarization of its own is like here, there is no compensatory pass. It will not be rearranging for the normal sinus rhythm. Usually what happens in a VVI, if there is a pacing lead and then a patient's own rhythm is coming, then it will readjust for the normal sinus rhythm. It will readjust for the timing, and then after the fixed time, it will, if there is no pacing lead, it will trigger. So it will be like this. But here, if there is a fixed ventricular pace, and if there is something coming in between also in VOO, that is a ventricular normal depolarization, it will not sense only. So there will be a fixed ventricular pacing at regular intervals. Whatever will come in between, it will be there also. So Vivo mode, there will be absolute AV dissociation, asynchrony, and it will be haphazard. But only thing is that it will not sense unnecessary electrocautery emission, and it will not going to assist. Okay, this is of the basic of the ventricular modes and the pacing modes. We will discuss further in the future.